All right, so today I thought I would talk a little bit about, there we go, about kind of my OSU roots and my work with Dr. Hill, because I know, you can hear me? Okay. I know I've seen the names of some of the other named lecturers for the Richard and Leonora Hill Endowed series, and they're phenomenal people, but I don't know if any of them are Buckeyes. Okay. So I am definitely a Buckeye, and I definitely owe my current research endeavors and interests to what I learned while I was a student here at Ohio State. So I came here from that school up north, and that's why I think Dr. Barr always teased me, but I was able to join here and become a student in 1988. And in 1988, even when I was a first-year student, Dr. Hill approached me and said, hey, I'd like you to work in my lab and, learn some of my research principles. So I had the distinct pleasure of training under him and learning his EOP, his equivalent oxygen percentage technique, which we'll talk about for a few minutes here. But I'd like to just kind of go back in history. I hope you allow me to do that, because I know there's some students here and you need to understand the legacy of the tremendous contact lens heroes and greats that came and spent some time here at Ohio State, and Dr. Hill being one of them. So Dr. Hill trained me on his technique, and I first worked on white albino rabbits. And I think in this physical location, in this space, which was the basement of the optometry school then, and right in between the student lounges, he had his lab. And I would go across, oh, hi, Dr. Early. I would go across campus and bring these white albino rabbits back from the animal facility, and I would put contacts on them, and then I would measure the EOP technique on these rabbits. And my fellow students were like, what is she doing in that dark lab? And Dr. Fote, you came in and you got to see what I was doing a couple times. So after we did all this work on rabbits, I then moved into doing the EOP on humans. And that's when Dr. Hill had to say, gee, I'm the dean now. I don't have as much time to spend to train and mentor you. So he asked Dr. Fink to kind of take me over as her graduate student. So I became Dr. Fink's direct graduate student, with Dr. Hill being our grandfather kind of mentor from there. So there's other greats that I had a chance to work with at Ohio State. Dr. Carney was here, Dr. Leo Carney. He's from Brisbane, Australia, but I think he was doing like a 2 or 3 year sabbatical. Do you remember? And so I was able to work with him in his laboratory, looking at the stability of contact lens solutions. And then, as Dr. Zadnik mentioned, the CLEX study was born while I was a student here. And I won't forget the day that Dr. Barr came into the advanced contact lens practice course and said, we got funded as NEI planning grant for CLEC. And I don't think, Carla, you were here yet. And then a few years later, Dean Zadnik, I should stop saying that, Provost Zadnik, took over as the PI of the study in general, and took that for 8 to 10 years further. And as she said, I was still able to participate as a young graduate up at Case Western Reserve University, where I've actually now been the entire time for 32 years. So what is this EOP technique? So this is what Dr. Hill pioneered, and it stands for equivalent oxygen percentage. And we use this probe, this polographic sensor, with a polyethylene membrane over it. And this polyethylene membrane was actually a dry cleaner bag. And seriously, we cut off these little squares of dry cleaner bags and put it over this probe. And the thickness of that polyethylene membrane was just thick enough and it held the oxygen, so that when you put the contact lens on the eye and then removed it and then put the sensor on the cornea would steal the oxygen from that membrane, and it would show you an indirect method of the oxygen debt that just occurred on that cornea from wearing the contact lens. So it is an indirect measure of, or maybe more of a direct measure of, the oxygen debt that the contact lens induced. So these EOP curves have been published for many years in the historical textbooks. And Dr. Hill, is the great physiologist that he was constantly trying to make this more applicable to the clinician. The original EOP curves looked something like this, where they went on a scale from 0 to 21, where 21 being the percent oxygen in the air, and that would signify or be equivalent to no contact lens wear, and a daily wear, open eye, no contact lens wear. And a 0 EOP then would simulate what a PMMA lens would do on the cornea, a static PMMA lens with no tear exchange during daily wear as well. So EOP of 0 meant PMMA, non-oxygen permeable oxygen net, and an EOP of 21 would be that similar to the ambient air. And not only Dr. Hill, but others in that time kind of agreed that we need to have an EOP of about 9 or 10% to make a contact lens successful and acceptable for daily wear. So where I'm going with this is these EOP curves have continued to even influence me today in my practice. I not only do research, but I still continue to see patients, and I'm the director of the contact lens service. And most of the patients I see are transplant patients, keratoconus patients, but some really sick eyes with poor endothelial cell health. And so I was always, because of this work, thinking about the oxygen transmission and the oxygen debt to the cornea. And these EOP curves published here basically show some really interesting points that especially you students and contact lens specialists should remember, that at this high end of the hypertransmissible lenses, we're not really gaining too much more anymore by continuing to push that oxygen limit. No one ever said we had to have an EOP of 21 to be successful. We only need an EOP of about 9 or 10% to be successful. So it's great that we have these hypertransmissible materials, but going higher and higher oxygen in the DK units is gaining you very little, as you can see on the EOP, because the curves plateau at that end. But you gain a lot on the other end of the curves, where either the low, the medium, or even the high DK materials, you can make small changes in thickness or make small changes in DK, and you gain a lot on the EOP curves. So our EOP work was published in International Contact Lens Clinic. This was my master's thesis with Dr. Fink and Hill on prism ballasting of rigid lenses. But I think I got a lot more press from a series of articles that Dr. Hill allowed me to co-publish with him. So I was still a student, and I know, pardon the 80s hair, but I think it's the same picture over and over, but I was a third-year student, and then I was a fourth-year student, and then I was a recent grad up in Case Western. That's what the contact lens spectrum would always write. But we had a series of 8 to 10 articles that he allowed me to co-author with him. And what he did is he converted that EOP scale to something called a hypoxic stress unit that was a little bit more applicable to clinicians. So it went from a scale of 0 to 100, where 100 signified the PMMA closed eye state, that 100 hypoxic stress units would be what the PMMA lens would induce, and then 0 hypoxic stress units would be what the open eye state would be. And these are just a smattering of some of our contact lens spectrum articles that are only on paper. You can't even find this online anymore. But something like this middle curve, or this middle graph here, which basically shows the difference between just changing the DK value. It's the same material, Fluorix 300 versus 700, where DK of 30 versus 70. And you can see the higher DK materials have really flat slopes, meaning that we can free up ourselves and increase the thickness, or go to a prism ballast, or do whatever we want thickness-wise, and do very little on the hypoxic stress unit scale. So it gives the clinician more insurance and flexibility to play with designs, and even now into the scleral lens world, and not have to worry too much about what we're doing to the hypoxic stress on the cornea. Moving on to others in the field at the time, we're also kind of looking at DK over T as being not a really good way to monitor corneal health with lens wear, but looking at other physiological metrics. And Noel Brennan in particular pushed the concept of oxygen flux, and that even a DK over T of about 40 to 50 provided an oxygen flux of about 93% to the cornea. So again, pushing this oxygen limit all the way with these hypertransmissible materials is very, it's great that the manufacturers are going that way, but I have been always one that said, I don't see a whole lot of problems with traditional non-silicone hydrogels. And I still continue to fit traditional hydrogels very successfully because I know based on my EOP work and also Noel Brennan's work that we're giving the cornea about 93% of what it needs, even with traditional hydrogel materials. This isn't a traditional thickness, not prism ballasted thick plus aphakic lenses or anything like that. But for the traditional myope, they're going to do just fine. So how much oxygen do we really need? Well, again, it depends on the kind of eye you're fitting. Are we fitting, normal corneas or transplanted corneas? But the Holden and Mertz experiment told us that we need a DK over T of about 24 for daily wear, which corresponds to Dr. Hill's about 9 to 10% EOP. But what the Holden and Mertz experiment didn't tell you, if you read the fine print, the way that they got that number was by looking at the DK over T of a lens that didn't induce any corneal swelling. But what they didn't account for was that the cornea actually thins throughout the day. So it even thins after the 2-hour deswelling that occurs when you close your eye at night. So the cornea continues to thin. Its thinnest point is usually about 6 p.m. and it normally thins about 1.5% during the day. So when the Holden and Mertz experiment was done with that particular DK value, they weren't accounting for that thinning. And so in general, in their daily wear scenario, their predicted no swelling criteria practically resulted in about 1.5% of central swelling, which countered the expected thinning that would have occurred without lens wear. So we just kind of have to remember that what we really want to look at in terms of physiological response of the cornea to contact lenses is, does it impede the deswelling rate that traditionally occurs throughout the day? So I did get to publish and do some work with J&J in this area. We published this paper about 10 years ago, looking at that deswelling of corneas throughout the day with everyday contact lenses. And again, I'm kind of still a fan of traditional hydrogels. And we had patients wear Acuvue 2 and then 2 silicone hydrogels. So Acuvue 2 is a Edafil Kane, a non-silicone hydrogel material. And then we looked at Air Optics and Biofinity, silicone materials. And good news was that they all allowed the cornea to thin throughout the day. So we did not impede the deswelling throughout the day. Granted, the Edafil Kane didn't do as good as the other materials, but they all did allow the cornea to deswell. So that again goes along with everyone else's work that we are still providing the cornea with almost what it needs with a thin regular hydrogel. And yes, we can do better with silicone hydrogels as well. But this work kind of just sets up where I'm going. It kind of tells you where I came from so you can kind of understand the work I'm doing today. So now we have to talk about the corneal endothelium, because the corneal endothelium and corneal swelling are obviously very linked. And any swelling that we induce through hypoxia or through contact lens wear is really kind of controlled by the endothelium. So it continues to work from it to deturgest the cornea, especially when the cornea goes into a hypoxic anaerobic metabolism. So another great I have to talk about is Dr. Schessler. So he is another OSU phenomenon who rose to become the dean as well. And in 1985, which was just a few years before I came here, he published this article in IOVS basically showing that PMMA wear caused polymegathism and pleomorphism. And he really became internationally known for his work in this area. And ironically, his graduate student was Eric Stalker, whose position I took over at Case Western Reserve University. So Eric was the contact lens director for years, and then he decided to go into private practice. So I actually took his position over. So it all just keeps coming together. So they had schematics of polymegathism and pleomorphism, and they also had some specular images as well. And what I'm showing you here is on the left, different cell sizes and cell shapes, which signify polymorphism and pleomorphism from PMMA inducing this on the endothelium versus an age-matched control that never wore contact lenses. So we definitely know that even though the cell density may not go down, the morphology does, and it does change with hypoxia. So again, this was something that I was exposed to as a student and working with some of these really, really great legends. Okay, so all of that basically was the preliminary, work that started my interest and continued my interest in corneal transplantation. So this is the work that I've now been involved in at Case Western Reserve University now for almost 20 years. So one other thing that Dr. Barr did for me is introduce me to Dr. Jonathan Lass, who was my chairman at the Department of Ophthalmology. He's now not the chairman, but I still work with him closely. And he had longstanding interests in endothelial cell health and corneal transplantation. So Dr. Barr introduced me to Dr. Lass, who hired me. And then we've been working together now for 32 years ever since. And John Lass has always wanted to do multi-center clinical trials, and I have the same passion, so our interests merge very well. So I'm going to jump into talking about our work in corneal transplantation, but I'm going to give some of the students just a super brief overview of the different transplantation techniques, because each study that we've worked on has looked at a different technique. So penetrating keratoplasty versus some of the endothelial keratoplasties. So the penetrating keratoplasty is the full thickness corneal transplant that removes the entire cornea from the epithelium to the endothelium. Needs to come from a donor, of course, and then get sutured in place, and lots of long-term healing, lots more rejection, irregularity, etc. So these are the patients that still see us today, because a lot of them need contact lenses because their corneas are so irregular even after transplantation. Here's an example. So when it works, though, it works really well. And here's an example of a patient I'm still seeing today. Now, what do you notice on his transplant that looks just very different? Yeah, it's square. So if you see a square transplant, it's at least 50 years old. So those were the initial transplants that were done in the United States. Castroviejo in New York. There was another ophthalmologist on the West Coast, both of them just doing square transplants. And this is a patient of mine that saw Castroviejo and in New York City, and is still seeing 20/25 out of this eye. It's still clear. It's still withheld pseudophakia. So, I mean, he had cataract surgery. And the only drawback is that he has recurrent keratoconus. So it's very, very steep. But he's still wearing a small corneal RGP and doing very well. So when these transplants work, they work well. And the endothelium still continues to pump very, very many years later. Including this transplant is probably older than the patient himself. So this could be a 100-year-old tissue at this point. Another type of transplant is a DALK, a deep anterior lamellar keratoplasty. Now, in this case, we don't remove the endothelium. We're just going down 2/3 into the cornea and letting the patient retain their endothelium. So it does make the eye stronger and less chance of rejection, because the number one layer of the corneal donor tissue that causes rejection is the endothelium. So we really don't see any endothelial rejection. And mostly the endothelium doesn't even really change that much, including the cell count in these DALKs. And then endothelial keratoplasty. So what's really evolved in the 30 years that I've been in practice is they used to do penetrating keratoplasty on everybody, regardless of the cause. So you would have had Fuchs endothelial dystrophy, and they still had to do a full thickness penetrating keratoplasty because that's all they knew. Now we only replace the layer that we need to replace. So endothelial keratoplasty has evolved itself, but it's only transplanting the faulty layer or the corneal endothelium, which for the most part is because of Fuchs dystrophy or sometimes pseudophakic or aphakic bullous keratopathy. So a little bit about the history of endothelial keratoplasty. It has also evolved. We've gone from names like DLEC to DSEC to DSAIC to now DMEC, where we're transplanting less and less and less and less tissue, where DMEK is basically endothelium decimase, and that's about it. Whereas the DSECs have some posterior stroma. So there's just variations on a theme of what they did in the early days. They actually did take away some of the patient's stroma. So there was this exposed, this is in the recipient, exposed stromal bed, and then they transplanted the tissue into kind of that rough pocket that they created. But now they just strip the endothelium, they don't touch the stroma, and then they transplant either this DSEC, which probably has some ultra thin posterior stroma still attached to it, or even a DMEK, which is even thinner. And we have these kind of anterior segment OCT images that show that it can be transplanted with sutures, with an air bubble in place, this little interface fluid between the recipient stroma and the donor cornea will just kind of eventually go away on its own. And you can be seeing very, very clearly in 6 weeks or 8 weeks postoperatively with no sutures, as compared to that PK that kind of took a whole year to rehabilitate. Although they are probably putting us a little bit out of business, the specialty contact lens fitters, because we're not getting these really fun distorted corneas anymore. But you can see, like, if you were a patient, wouldn't you much rather, heal in 6 weeks like that versus still looking like with the PK here at 6 weeks? And then with DMEK, which is even thinner than DSEC, you almost can't even see that transplant on the cornea behind the slit lamp. So, this technique has truly, truly evolved. Okay, so what I've been able to participate in, being up there in Cleveland and finishing my PhD was being able to jump into clinical research and actually coordinate and oversee some of these studies. So the NIH has had a long history of funding consortia. They funded the PDIG trials, they fund the DRCRNet trials. In cornea, they haven't funded as many. They funded CLEC, and they have funded this series of corneal transplantation studies. So the first was the collaborative corneal transplant studies, the CCTS studies, which those were in essence looking at tissue and histocompatibility matching. And the question there was like, do I have to tissue match before I transplant? And the answer is no, you don't. So we moved on. And then they did the cornea donor study. And the question in the cornea donor study was looking at donor age. And so I'm going to show you some data from that, whether or not an older donor versus a younger donor mattered in terms of graft success. And then the cornea preservation time study, which I played a very large role in, looked at the effective preservation time of the tissue. We'll talk about that. And currently, we are running the donor diabetes study, or the DEX study, which looks at the impact of diabetes in the donor and whether that makes a difference. So the beauty, though, of these studies is I'm going to introduce the study to you and tell you a little bit about its main outcome, but really, some of the side studies were even more interesting. They had to do with looking at the procedure itself. So the cornea donor study did penetrating keratoplasty. So we learned a lot about penetrating keratoplasty and endothelial cell health. And then the cornea preservation time study looked at DSEC, and the diabetes study looks at DMEK. So we have these hidden agendas within all of these studies that I actually find more interesting, and probably you will too, as opposed to the actual outcome of the specific aims. So the cornea donor study, this was done in the 90s. And again, we were looking to see whether or not the age of the donor mattered in terms of graft success. And these were all penetrating keratoplasties. And the patients that were enrolled all had endothelial dysfunction. So today, none of those patients would have had penetrating keratoplasty. But anyway, they were not keratoconus patients, so they all had some form of endothelial dysfunction. So the main outcome was really that there was no difference in donor age. So they stratified them by the age of 66, older or younger. And after 5 years, which was their first outcome time point, they found no difference between donors that were younger and donors that were older in terms of graft success. And really, all of them did pretty well, 86% graft success regardless of the age group. So I still use that metric, like if a patient's having a penetrating keratoplasty, even for keratoconus, we usually say, you have 80 to 90% success in all of these grafts, 5 years out. That's still a really good metric, which is true to this day. But here's where I got really interested. So this is the endothelial cell loss, because still really interested in the endothelium here. And what the PK data show from the cornea donor study, that the endothelial cell loss is really prominent in the first 5 years. So it doesn't happen in the first 6 months or necessarily even in the first year, but between year 1 and year 4, there is a very rapid decline in endothelial cell density in these penetrating keratoplasty grafts. So if you remember from optometry school, a typical cornea in a 50-year-old has a cell count of about 2,800 cells per millimeter squared. But it then rapidly drops off to hover around 500 to 600 cells per millimeter squared after about 5 years. That is a 75 to 80% cell loss after penetrating keratoplasty. And all of these grafts are clear. They're not, the failed grafts have been removed. So any of the, corneas that were regrafted or failed or cloudy are not even included in this analysis. So that means that we're looking at clear transplants that are still pumping very, very well, but with only about 500 to 600 cells per millimeter squared. So again, this is about a 75% cell loss. I mean, think about it. I mean, what other tissue do you know can lose 75% of its anatomy and still work as good as it's working? Because all of these transplants, and I showed you the 50-year-old graft, is still pumping really, really, really well. So I was just fascinated by this. And then the cornea donor study got extended. Just like COLLECT got extended, so did the cornea donor study. And instead of 5 years, they followed them for 10. Those are the days where you didn't always have to write a competing renewal, and your NIH program officer somehow found a way to do this. And that's what they did for the cornea donor study. And the graph changed a little bit, where the older donors seemed to actually do a little better than the younger donors at 10 years, but still that was not statistically significant. But looking at the cell counts again, and again, I'm more interested in these ancillary studies, that the cell loss kind of plateaued. It's probably so low it can't go any lower. So it hit its bottom limit. So the good news was after 5 years, where it hovered around 500 to 600 cells, it kind of stayed that way even through 10 years. So these are now kind of the graphs that we're aware of, but I think the lessons here is, like, if you see a penetrating keratoplasty patient that's 10 years out, which is really common, right? They're all like, were transplanted for keratoconus or whatever other disease 20 years ago, even 30 years ago, you have to assume, even if you don't have a specular microscope, that you're fitting a contact lens over a cornea that has very, very low cell count. So just keep that in mind. You can actually look at the cell count in one patient over many years. These pictures come from my colleague, Beth Ann Bennett, who was a COLLECT photographer, and I still work with her to this day. She now leads our reading centers. We have a very well-known cornea and retina reading center at Case Western. And so she was able to provide the same patients' images over 10 years in the cornea donor study. So you can see here at baseline, this is still taken in the eye bank, that the cell count was pretty high. It was over 2,300. And then each year it goes down, goes down. And then we kind of plateau at, again, these lower, you see bigger cells, you see a much, it's a clean mosaic, but they're just bigger, larger cells. But then at 10 years, they're kind of looking a little ill, and but yet still pumping. So I think we need to start looking more at morphology rather than cell count. Is kind of, we're seeing more polymegathism and pleomorphism here. So there was a really nice quote from Bill Bourne that he said in the 90s that I really like to remember, that essential endothelial cells of successful corneal transplants 5 years after keratoplasty, or even 10, form an unstable monolayer with continued accelerated loss of cells and abnormal cellular morphologic features. So we know that they're plateauing in cell density, but I think their morphology does continue to change, as I just showed you. So fast forward then to the endothelial keratoplasty. So the penetrating keratoplasty, we see the cell counts like the blue line here, where they kind of slowly dip and then rapidly dip through 5 years. In endothelial keratoplasty, we see a different trend. And so it dips quickly in the first maybe 6 months to 1 year, and then it dips slowly thereafter. So not too many people have followed endothelial keratoplasty out past 3 years. So we don't really know what happens after that, but we are very, very interested in that ourselves. And this is what has made up the secondary aims in all of our NIH-funded studies. So I got deeply involved with this 4th NIH-funded cornea preservation time study. And this is John Lass, who as I mentioned, was my chair, and he has been the chair of both the CPTS study and the DEX study that we're currently running. This is a consortium between the Jaeb Center for Health Research. They're a group in Tampa, Florida that runs all the PDIG trials. They also run the DRCR trials, and they also ran the cornea donor study and then have partnered with us to run the CPTS and the DEX study. So when I mean partner, I'm the director of the coordinating center, so I direct all of the sites and the eye banks, and the Jaeb Center does the statistics and all the database stuff, which I don't like to do, and I don't have the resources to do, but they have phenomenal resources. Roy Beck is in the middle. He was the executive director of the Jaeb Center. He's now their medical director, and Marianne Redford has been our NIH program officer this entire time. So I'm going to tell you a little bit about the cornea preservation time study first. So this study looked at DSEC, not DMEC, but DSEC had a little bit of posterior stroma in the donor tissue. So we had, this was 1,330 DSEC surgeries, and we had 40 sites across the United States and 23 eye banks. So it's not uncommon, for example, an eye bank in Minnesota to produce, supply tissue to a doctor in Cincinnati. I mean, they're flying these corneas all over the country and put them on FedEx. They put them on commercial planes. It's amazing. So sometimes I even have seen a Portland, Oregon eye bank supply a site in Boston. So they're literally flying them all over the country. So the reason we did the cornea preservation time study was because there had been a bias of corneal surgeons to only want to use corneas that were preserved up to 7 days, when the FDA has approved for them to be preserved up to 14 days. So when the donor passes, there's all this FDA-approved preservation media in the United States, and they can easily and clearly sit approved up to 14 days before transplantation. But our surgeons have kind of, based on their training, and then they go into practice, they kind of had this bias, which was not evidence-based, that they wanted the 4, 5, 6-day-old corneas. They didn't want the 10-day-old corneas. They thought they were old corneas. So those older corneas, as you can see here in the purple, they were shipped internationally. They were shipped to Saudi Arabia and some of these other countries and used very successfully. They published those findings. And corneas harvested in the US and shipped internationally at day 10 and 11 and 12 were still transplanted with good success. So we wanted to try to retain more of those corneas in the United States because these surgeons, or actually the eye banks, wanted more time. They were getting hit with, more serology testing for infectious diseases. LASIK is becoming more common. They have to have more time to screen not only the donor, but the corneas. And so sometimes getting it out the door and shipped across the country in 4 or 5 days was actually pretty difficult. So the eye banking community really wanted to see some of these results. And we created a non-inferiority study to show, our hope was to show that the older corneas were just as good, non-inferior to the younger corneas. And so it was a 1-to-1 randomization And in the end, we had 675 surgeries in the 0 to 7 day group and 655 surgeries in the 8 to 14 day group. But we had this a priori secondary aim that, thank God we did, because if you do something a priori, like before you actually analyze your study and you think about it, even though we weren't powered for this aim, you can actually make legitimate conclusions. So in the younger group and the older group, we subdivided the buckets even further. So we had a 0 to 4 day group, a 5 to 7 day group, an 8 to 11 day group, and then a 12 to 14 day group. So we were powered for the main comparison, but we had this secondary aim that we always planned on looking at, and we stratified and block randomized the eyes so that we would have enough corneas in each of those buckets as well. So in the end, the main finding was that we did have a lower percentage of success in the older group. So it wasn't a big difference. It was 92% versus 95%. But that was a statistically significant finding. So let me just talk a little bit about non-inferiority for those of you that might not know statistics as well. Non-inferiority means we're trying to show that, you know, one group was not really worse than the other group. And you have to pick a non-inferiority limit that you're all going to live with. So you get your focus groups together and you all agree, okay, like I think 4% is what the surgeons told us. If you can show us that, you know, the older group is no different by 4% difference to the younger group, we'll accept that and we'll be happy to use the older corneas. So this was this a priori non-inferiority rate. So when we did the analysis, the point estimate was that they were only 3% different. But in non-inferiority, if the upper end of the 95% confidence interval crosses your non-inferiority margin, then you can't claim that it's non-inferior. So our upper limit of the 95% confidence interval was like 5.4%. So we could actually not claim that the older group was non-inferior. So the older group was inferior. So we were kind of sad about that. And if you look at what we did a priori, like I said, we had those smaller buckets. Thank goodness that we did, because we were not able to show that the older group was non-inferior. But when we looked at it by smaller subgroups, we were able to show that up to 11 days, the success rate didn't change. So really, the ones that were dragging us down were the 12 to 14 day old corneas. And here's kind of the survival curves where you see the 3 smaller subgroups all hovering together in their survival curves, but the older corneas are the ones that kind of dragged it down from the start. So the good news is that we were able to tell the eye banking community and the surgeons that it's really okay to use a cornea up to 11 days. And that was what we published and what they are now accepting in the eye banking community. So now talking about endothelial cells, okay, this is our secondary aim in the same study. So we published this in JAMA Ophthalmology, and this is what our cell loss curve looked like for DSEC, and this is out 3 years. So just kind of like that other graph, we see the largest cell loss in the first 6 months, and then it kind of goes onward after that, but not to the same rate that you see in penetrating keratoplasty. So here you see the same eye over 3 years. Again, very small, compact cells that get larger and larger and larger with time. But we found a very, very similar trend to the graft success data. So they all stayed pretty similar out to the 12 to 14 day group. So it kind of paralleled the cell loss data paralleled our findings to the graft success data. So again, that 12 to 14 day group didn't do as well. They had a higher rate of cell loss. But look, it's only about 41% cell loss compared to PK, which was 80% cell loss. So far through 3 years, it's all we have the data on, the cell loss is not as great in these DSECs, and probably the same will be true for DMECs. But not that that matters too much to us as contact lens fitters, because we're not fitting contacts on these DSECs. Their anterior cornea is smooth. They don't have irregularity. They didn't have any sutures. So they're all wearing spectacles anyway. So they don't need our services in fitting complicated scleral lenses on them. One other thing we did look at was, what does rejection do? What does an episode of rejection do to the cell loss data? So that's important to know, because, you know, eventually these grafts do fail, and they fail often from endothelial decompensation, where the graft just over years just really gets thick and cloudy. So with each episode of rejection, which is an inflammatory acute event, we had about a 6% rate of rejection in CPTS, but with each episode, it decreased the cell count by about 10%. So if you look at eyes that experienced rejection, they had a 48% cell loss versus eyes that never experienced rejection at a 38% cell loss. And that was highly statistically significant. So again, kind of a cool ancillary finding of this study. So clinically, then, you know, you really want to control rejection episodes in all of our patients, DMECs, DSECs, PKs, because this episode of inflammation decreases the cell loss even further. So now we're running the diabetes endothelial keratoplasty study. And the rationale behind this study is that the donors are overpopulated in diabetics. So what I mean by that is, you know, people talk about a diabetic epidemic, and about 1 in 10 Americans have diabetes, but in the donor pool, 1 in 3 donors are diabetic. So in standard of care, if you're not in our study and you're having a transplant, you have, you know, 1/3 chance of getting a donor from a diabetic. Now, why does that matter? Well, the corneas are more brittle from diabetics, and the eye banks have a harder time stripping it. So when they're trying to strip that Descemet's, you know, away from the stroma, they tear a lot easier if the donor was diabetic. So every donor is considered a gift. So they use that word. It's a gift. It really is. And eye banks also have financial implications. They probably sell them for $3,500 or $4,500 each time they get a tissue out the door. So they're invested in not using a tissue that's going to tear or rip. So they were avoiding diabetic donors for endothelial keratoplasty. They were using them more for the penetrating keratoplasties that didn't have to be stripped. And also, a bias was starting amongst the surgeons, just like they had a bias about preservation time, and they were kind of shunning and shying away from diabetic donors. So if that continued, like, we're going to have a problem, because we can't like shy away from 1 out of every 3 corneas. So we created this study to look at the impact of donor diabetes. And so we're currently running this with kind of the same team. John Lass is still the study chair. I'm still the director of the coordinating center. Beth Ann Bennett is still the director of our reading centers. Jabe is still involved. And then we have a co-chair now, Marianne Price, who is a corneal physiologist, and her husband, Frank Price, out of Indianapolis. So she's our co-chair. And Marianne Redford is still our program officer. So we don't have data. We're still in the enrollment phase. We're now randomizing 1,420 eyes, and it's a 2-to-1. So we're mimicking standard of care, where 1 out of every 3 eyes will get a diabetic donor, and 2 out of every 3 will get a non-diabetic donor. So we're telling patients that if you participate in our study, you know, you don't have a higher risk of getting a diabetic donor. If you were out in standard practice, you still have a 1 in 3 chance of getting a diabetic donor. So it's been very easy to enroll. We have 28 sites, and we have 13 eye banks. So our enrollment will end in June, and then we still have to follow these patients for several years. So more on that as we continue. And also, cell loss is a secondary aim. So we will have cell loss data on DMEC in this population. This is a DMEC study. Okay, so tying it all together now. So, you know, my interests in swelling and corneal physiology, EOP, back to when I was an OSU student, to transplantation, both in my clinic and the research world. And now coming back again to seeing patients in the clinic that have transplants that were fitting with contact lenses. So, remember we were talking about what DK over T or EOP do you need to avoid corneal swelling? Well, we needed an EOP or a DK over T of like 24, but with scleral lenses, we're not getting that. There's a very nice equation that Langis Michaud published showing that you have to take into account the decay of the tear layer, the decay of the lens itself, the thickness of both the tear layer and the contact lens. And then you can calculate what the DK over T is of the system. And, even in the best case scenario, we might be hitting 25, but that's a lot lower than the 80s and the 90s and the 100s that we could do with soft lenses on normal corneas. And on top of that, these corneas are not normal. These corneas have cell counts, remember, of 500 to 600, 80% cell loss. So this has really fascinated me. We published this case series with some graphs that had acute corneal swelling with scleral lenses, and that we began to scratch our head like, what is going on? So Sophia, she an OSU student? I think she was, Sophia Murillo. Maybe she came from Indiana, I can't remember, but she was one of my externs, and we saw 2 or 3 of these patients together, and I said, well, let's publish this. So these are like 20 to 30-year-old transplanted eyes. They all happen to have keratoconus, and they got recurrent keratoconus. And you can see this extreme ectasia here. This is the left eye, so inferior temporally. And 2 days after getting a scleral lens, she comes in a lot of pain with this acute corneal edema that I highlighted there. And she had a low cell count, of course, 590, as you would expect. But she just picked up this beautiful scleral lens I fit, and then she comes back in pain and terrible edema. And this edema crossed the graft and the host. A few weeks later or months later, I can't remember, but similar, another PK for keratoconus. This guy also had LASIK. So he had a thin cornea, but again got thinning. And also he was out of town, but he had an acute episode of edema, which some people thought was a rejection, but there is no KP or other signs of inflammation. So you note that the edema is always in the same location as the ectasia. So the first one was here where the ectasia was, second one here where the ectasia was, and then the third one, which is kind of unique because we had superior recurrence. And so this is a patient I'm still seeing today where she also had this sudden onset corneal edema in the area of the ectasia, and also soon after getting a scleral lens. So we were thinking, what are we doing? Are we inducing so much hypoxia with these scleral lenses that is causing the endothelium to truly break down? Or is this high drops? And in the end, we propose this is actually high drops, that we're getting a split in that the donor recipient wound where the Descemet's never really reforms. And maybe the pressure and the negative pressure or the trauma of putting these scleral lenses just caused it to break, because it was always in the area of that recurrent ectasia. Now, it could also just be that, we did stress that endothelium, but anyway, 2 or 3 of those patients were regrafted successfully, and the third, she just healed. About 6 weeks later, the edema's gone, and I still see her today, and she was never regrafted, and she's actually, again, happily wearing her scleral lens. So, but this still always stuck with me, like, what is going on when we're putting scleral lenses on some of these grafts? So I was able, and this was at one of these camps, it wasn't a camp, but what would you call it when we brought all of the researchers together and we put, I guess like a summer camp, I guess. Anyway, this wasn't that long ago, but I attended it, and we got together with Langis Michaud and Muriel Shornack from the Mayo Clinic, Chris Sint from Iowa, Tracy Gwynn from SUNY, and Tim McMahon from Illinois College. UIC, Chicago, University of Illinois, Chicago. And we all saw the same kind of patients. We all saw these 20-year-old grafts that we were fitting with scleral lenses. And we wanted to know, like, what are we doing? Are we inducing swelling? And does endothelial cell count even matter? Because we knew we were fitting these corneas that had 500 or 600 cells per millimeter squared. So we were funded by the American Optometric Foundation through the Allergan grant mechanism. And we just presented our posters at this past academy in New Orleans. And Rachel's going to write this up for me. So what we found is that across about 30 patients that we enrolled across all of these sites, that these were all grafts, that penetrating keratoplasty grafts that were at least 5 years out, but practically they were more like 20 years out. And because we wanted them to be on that range of the curve where they plateaued, where the endothelial cell count won't go down any further. And they were not all wearing contact lenses, but in general, the first thing we looked at was what is the regional variation of cell density. And because all of the other studies that we looked at only looked at the central endothelial cell density, but now these Conan instruments, we can get mid-peripheral cell counts. So we looked at the cell count in the mid-periphery, and we found that the cell count is always highest in the middle, and it decreases as you go out there towards the periphery. So whether it's inferior, nasal, central, or temporal, the cell count is lower than it is centrally. And we can look at maxes and mins, but we even had cell counts as low as 277. And again, these eyes are still clear, and they're wearing contact lenses successfully. So we published kind of this regional variation. We showed some pictures which weren't that great, but we have better pictures. And this is data looking at the corneal thickness changes throughout the day and non-contact lens wearers. And I know it's hard to see, but we saw a counterintuitive regression line where eyes with lower cell counts actually deswelled throughout the day. So what we did is we measured these eyes in the morning, like 10 o'clock, and then we measured them 6 to 8 hours later. And these are non-lens wearing eyes. And the slope of this regression line was opposite to what we thought, but eyes with the lower cell counts and going as low as, 400 were actually thinner in the afternoon than they were in the morning. So again, remember the cornea does thin throughout the day, but we didn't think that the eyes with the really stressed endothelium would do that more than the eyes with better endothelium. So it was a little counterintuitive, and it could be that that eye just was still actually swollen in the morning. It took it a lot longer to deswell from its overnight stress, possibly. But we're just still learning a lot about what these eyes are really doing. We also have data with contact lenses on the eye, and we didn't see anything really exciting. So when the cell count got really, really low, the eyes were not really swelling. It wasn't predictive at all. So you had eyes that barely swelled with a cell count of 500, and you had eyes that swelled more if they had a cell count of 1,000. So what we're learning, and we have a lot more to write up, is that cell count maybe just doesn't matter in these eyes, and maybe we need to be looking at things like morphology, like Goutte, that you can see in these transplant eyes, that's CV and Hex and some of those polymorphism metrics to see if we can help predict. And maybe there's no correlation. Maybe we don't need to worry about the cell counts because these cells are amazing and these monolayers are continuing to pump for years and years and years, no matter what you do to them. So anyway, it's an amazing cell. All right, that's all I had, and I'll take any questions.
I'll give precedence to those of you who are here. Any questions from the audience? Something. Don, then Bondally, then Marielle. Oh, Marielle, he wants you to go first.
Great talk.
Thank you.
You were mentioning this less concern about cell count, more about morphology.
But you mentioned for the diabetic study that one of the secondary outcomes that you're measuring is cell count. Are you also doing anything with cell count? Yeah, actually we are. So you can get those metrics very easily. And we are this is the first study where we actually are going to look at coefficient of variation and percent hexagonality. Yes, we are doing that in the current study.
Great idea. Bonnie.
Question,
Oh,
when you reach the point of. where
Yes.
give them the microphone, because
so Jenny's gonna read questions from the Q&A.
who I'm just saying that,
Oh, repeat the question. Bonnie, you say it and then I'll repeat it. How's that sound?
My question is actually similar to Marielle's, but my question has to do with, have you considered looking at the metabolic activity in some way? I don't know anything about endothelium, if you can measure metabolic activity, but it would seem to me that you might just have a few very healthy cells that are capable of breaking down glucose and metabolizing glucose correctly. It kind of feeds into your question about patients with diabetes and being donors. We know that patients with diabetes have terrible mitochondrial dysfunction. And so I don't know if that will play out in your study, but I'm just curious about other thoughts on measuring something besides morphology, something more technical.
In the cornea, yeah. Okay, yeah, the question is, any thoughts about looking at anything metabolically in the endothelial cells in particular? And I actually don't know how to do that in vivo. I mean, the cell density, the cell count, the CV and the hex are well-established signs of toxicity in cell health, like the FDA mandates that now for drops and devices. A lot of the glaucoma devices were pulled off the market because they saw harm to the endothelial cells. So our reading center is so popular because they're doing all these FDA studies now for new drops and things. So it's a well-established metric about stress. Yeah, I don't really know. Now, in our diabetes study, we are looking at advanced glycation end products in the donors. So we have a skin biopsy on every donor, and we will be able to look at kind of the metabolism, I guess, in these AGEs, if you're familiar with advanced glycation end products in the donor, and we will be able to extrapolate that to how severe their diabetes was. That's the second and third aim in our study, to not only look at the yes/no diabetes question, but to look at severity of diabetes.
I was thinking, could you assess their metabolic capabilities by having just an itty bitty stress test? Not a great stress test because he was compromised, but could you swell the corneas and engage their pumping?
Patients, yeah, but probably, yeah.
But I do just a little bit of stress because I'm remembering some presentation from an ARVO ages ago where Bob Mandel went too far and some corneas didn't really recover. And I mean, he felt terrible. He was very honest and open about compromising these corneas and trying to probe metabolic activity. So,
Interesting.
stress.
I'll have to look.
It
Thanks.
might be only an ARVO. I don't know if they're ever published. It might only be an ARVO abstract. So that might be a deep rabbit hole for
his life, I think. Is what he said.
yeah, well, it wasn't really because there was a talk after that, but neither here nor there. Jenny, do you have some questions? Do you have a microphone or would you like mine? Yeah, but the people can't hear you.
Okay.
The people who asked it can't hear you. Okay, we're out. Just yell.
Okay, I can repeat it. It's okay.
Well, asking, are saying, coronary arteries have a coating of glycocalyx on the endothelium. Corneal endothelial cells have a similar coating.
Not that do corneal endothelial cells have a glycocalyx coatings like coronary artery cells do? Not that I know of, so I could be wrong about that, but I don't think so.
Lucky saying, loves the story of part of your research. He wonders if there's any research that indicates whether a donor is wearing contact lenses that has an impact.
So the question is, if a donor wears contact lenses, would that have an impact? And we don't have that data. So yeah, it's really hard to get donor data. So we would not have that data. We have history data of coexisting diseases. We have obviously demographics. We have smoking, but not that, it's not very good. So we're not relying on it, but no, we wouldn't have that data.
Here's a clinical question. If there is a patient who's keratoconic, has had 2 PTKs, and the second was saved by a DSEC, could a scleral lens still be fit with limited hours of wear?
So a clinical question, you have a keratoconus patient with 2 PTKs or PKs?
Assuming that's
PK, because PTK, phototherapeutic keratectomy, I would not think so. So you probably mean PK, penetrating keratoplasty. Okay, 2 penetrating keratoplasties and a DSEC, yes. Yeah, no, that's very common now. So a lot of the penetrating keratoplasties that are failing, but they're actually relatively smooth, or maybe the patient's already wearing a contact lens that they kind of like, then oftentimes they'll just do a DSEC or a DMEC beneath the PK. So I would not treat it any differently. Yeah, I would absolutely still be able to fit a contact lens. In fact, probably better, because I know they have kind of a replenished endothelial cell layer there.
That's Steve Schroeder.
Oh, hi, Steve.
Is that all we got? Is that what you got?
That's everything.
Okay, well, I want to thank you all for attending, and we'll do a medal presentation. But I have to tell you, Loretta mentioned she didn't think any of the previous Hill lecturers were from here. And I will say this is certainly the first time that one of Dr. Hill's mentees or proteges has presented, and I'm sure he is smiling down with great pride tonight. So it
That's
gives me
great.
great pleasure to give you this Hill
Aw,
medal. And
Thank
thank
you.
you all for attending, and we do pictures in a minute, okay? So thank you all for attending. Please join me in thanking Dr. Thomas.
Thank you.